town hall meetings. So we want to give a few moments to Councillor Kidwell to also share a little bit and introduce himself to you, so you can all begin to know him a little bit if you don't already. We've got a lot going on across the nation and in the Cherokee Nation this evening. So I think without further ado, we'll go ahead and get started with our program this evening. So Councillor Kidwell, would you like to start out here, just share a little bit about yourself and what you've been working on? And I think we'd all be really interested to hear what the newest impressions about being on the tribal council are. What do you all think about us, right?
Yeah, I appreciate you putting this together, obviously, and everybody allowing us to come into their homes for a little bit here and talk about some important topics. And being my first time, I won't waste a lot of everyone's time, but I will tell you that when you talk about first impressions, if I know that I've only been on council for about 5 months, but I can promise you that it feels a little bit longer than that. There's so much going on that it's hard, honestly, to keep a good handle on everything that could possibly happen, or everything that might come across your inbox or your phone calls. And let me tell you, for the people that don't know, it is truly a 110% time and need with the Cherokee Nation and for at-large citizens. The phone doesn't stop ringing, the inbox doesn't stop going off, and those are all good things. They truly are. I mean, any time that we can be helpful and answer questions and be a part of the solution, that's something that we want to do. I'm still drinking from a fire hose, and I don't know when that's going to stop. I hope it stops sometime this year. But let me tell you, it's important that we drink as much of that as we can. I know Julia, Councilwoman Coach, there, she's old hat at this, right? She's been at this a few times, and I've gleaned a lot from her as well on how to handle certain things and certain situations, and I'll continue to learn, and hopefully I will continue to get better. But my first impressions are that the council, in my opinion, works a little bit better, honestly, than the initial impression that I had going on. The more meetings we go to, I think the better we get. And I think that anytime, every 2 years, when you have this council kind of change over a little bit, you get new personalities and you get new ideas and you get new people, and it takes a little bit to gel. I understand that I'm part of that gelling process, and I think each time we get a little better, and that's a good thing, right? And we'll continue to get better. The council, we're handling some not difficult issues, but they can be contentious issues at times, but most of the time they're not that way. And we all want to do what's best for the Cherokee Nation and its citizenry, and I think we are doing that. I think individually we're doing that, and I think as a group we're doing our best to do that. So I would remind everybody just a few things. Get people signed up. The Cherokee Warriors, the veterans, all those folks. Remind all those folks to get signed up in that Gadoogie portal. I know it can sometimes be a hassle, and there's issues here and there, and there are ways to get around those things. But continue to encourage people to get signed up, and continue to encourage people to be part of the Cherokee wherever we are, and continue to encourage people to play the best part that we possibly can in trying to stay connected during these unprecedented times, because that's truly what they are. We're doing our best to navigate this. And hey, man, I look forward to the day where we all get back together and have a potluck dinner and talk about and talk story. But those days aren't here right now. And just, encourage one another and look out for one another as best we can to get through this. And I know that we will. I know that we're a very unique people, and we can do it. We've been there before. And I want to encourage everyone to just look out for each other and keep everybody safe, keep each other safe, keep yourselves healthy, and we will be back together sooner versus later. I'm sure.
Thank you. Thank you so much. I echo your desire to be back out in the communities and being able to meet with people, and as you said, hopefully very, very soon now. Or if not very, very soon, at least not very, very far. I was joking around, if they're going to start handing out COVID relief funds, we're going to need about 35 additional at-large tribal counselors, right? You weren't there for the initial push, but I'll tell everybody, I responded, I counted them, to over 2,000 emails and phone calls in that came in that first month. I didn't answer them in the first week when they came in, but at least I was able to get to them within the first month or so.
I don't doubt it one bit. I'm sure you had your hands full.
It's there are so many at-large Cherokee Nation citizens, and we are very, very glad for those who are here this evening. Okay, so we will turn to the program for this evening, and I will introduce you once again to our public health officials at the Cherokee Nation. We have our Senior Director of Public Health, Ms. Lisa Pivik, who is here, and our Medical Director, Dr. David Gann, who is also here. And without further ado, Lisa, I guess, shall we turn it over to you first? With that, I think that's how we've done it in the past.
Sure, Councillor Coates. Thank you, Councillor Coates and Councillor Kidwell. We're pleased to be here this evening. Again, I'm Lisa Pivik, the Senior Director of Public Health. 2 years into pandemic, wishing and hoping we wouldn't be back here for another surge, but we are. We have lots of information for you this evening on the efforts that are going on within the Cherokee Nation, trying to keep all of our citizens safe and our communities safe. Excited to hear a little bit about what Dr. Gann has been up to this afternoon. We've had a really busy day, and I really appreciate all the effort he puts into it. Dr. Gann is the Medical Director for Public Health that we work together. And without further ado, I'll turn it over to him. He's got lots of great information for us, and I'll also be here to answer questions as well.
Thank you, Lisa. Councillor Coates and Councillor Kidwell, again, thanks for having us. A lot of information to share today. I'm going to share my screen and just go through a few slides, let you know what's going on. And I can tell you that what's going on is remarkable. I really never thought we would have the burden of COVID that we have today. Let's see. So the United States, these bumps that you see here, this is kind of when back in August of 2020, when COVID really started to show what it was going to do. And then when it got to the holidays of Christmas of 2020 and New Year's, we had our big surge. And it's when the hospitals filled up, and we had a lot of mortality and people got very sick. And then another little bump around spring break. And this was the Alpha variant, and then the Delta variant came, and we did a lot better with the Delta variant. Our ability to take care of people, our ability to test people, and just the general public's understanding of COVID and how to stay safe was there. And then Omicron came. You can see the tremendous burden. We went from averaging 250,000 cases a day to over 800,000 cases a day. And it looks like it's going down. After a long weekend, these numbers could be deceiving. So I can't really call it a trend yet. So we'll have to see how that pans out. Again, if you look at the mortality, here's that original surge when coronavirus first came to the US, and then the Alpha variant, tremendous number of Americans lost their lives here. And then Delta, we got a pretty good handle on that, but still 2,000 people a day were dying. And now Omicron is showing its true colors. And we're sitting right around 1,700 people per day in the United States are dying from COVID. And as best I can tell, I think the public health officials around the country are really good at classifying whether or not someone passed away from COVID versus passed away with COVID. And it's not too hard to figure out, but it can be a little confusing. Also know that as the cases surge, the average time from symptoms, if someone does pass away, to death is 3 to 4 weeks. So we expect the number of deaths to increase still. We're still at the beginning of the surge. Now, if you look at the number of cases by state, everyone's in the red. It's not even close. The surge kind of started in the Northeast, and then in a period of about 2 weeks, it absolutely swept the country. Just remarkable how contagious this virus is. So in Oklahoma, this bump here is last fall. This was the Delta variant. And you see in Oklahoma, for the general population, we're up to about 3,000 cases per day. And we really got a breather, got things under control. And then we had Thanksgiving and a little bump, and then Christmas and New Year's. And it just absolutely took off over a period of 3 weeks. 3 weeks ago is when this surge went exponential. You can see today we're at over 10,000 cases per day on average. And over the last several days, over 12,000 cases a day for 3 days in a row. Now today the report was 3,800 cases, and that's not unusual. After a long weekend, the number of people that get tested over the weekend goes down, so that the cases are lower. So again, it's too early to call a change in trend with this 1 day of it going down just a hair. And of course, our big concern, one of our big concerns, of course, is people in the hospital. So this is for Oklahoma. It's the total number of people in the hospital that have COVID. Now, not all of these people are admitted because of COVID, and the state isn't able to tease those out right away. But you can see the gradual increase in numbers starting with Thanksgiving, and it's just been steady. So I can tell you that the hospitals in Oklahoma have been full for several weeks. And we can see that a lot through our emergency department. When we have a patient who's ill from COVID or for some other reason that is too ill to be at Hastings Hospital, or if our hospital is full, trying to get them transferred can take 24 hours. So it's not unusual for our emergency department to have someone sitting there for half a day or a full day while we search for a bed somewhere. And we're sending patients to Arkansas and Missouri, and sometimes even Kansas, wherever we can find a bed for these. And we're making do. The staff is really quite remarkable. Now, Cherokee Nation, this graph shows our cumulative cases. We've had 34,000 cases. That was this morning. We've had about another 1,000 cases today. And you can see our initial surge here around Christmas and New Year's of last year, and then the Delta variant, and now with Omicron. We're averaging 693 cases per day, which is more than 3 times higher than our peak before. And we're testing on average over 1,800 people a day. Our positive test rate is very high, anywhere from 38% that we got last week, trending up to around 45%. So we look at the number of cases per day, and this is just Cherokee Nation Health Services. You can see after Thanksgiving, we bumped a little bit and then really went exponential with Christmas and New Year's. And we over 1,000 new cases a day for 3 days in a row last week, and then got close to that for the other few days. The 3-day weekend was a little off. We'll look at the testing numbers, but you can see we had about 333 cases on Saturday and Sunday, and then Monday, the holiday, we had 574. And then we're at 879 today. And I think when all the numbers finally come in, all the test results will be around 12 or 1,300 for today. We're going to break another record. You can see, back with the Delta surge, most we had in a day was 299, and it immediately dropped. Every Monday was always a big day, but we've had a sustained increase in cases. So look at the 7-day moving average. It's a little more dramatic. Here's the Alpha variant from a year ago, and then the Delta variant from the fall, and then the Omicron, just through the roof. If you look at the number of cases per week, it's even a little more dramatic. Again, at the original surge a year ago, we had 1,400 cases in a week, and we really struggled with that. With the Delta variant, we hit 1,100, and I think we handled that really well. But then just through the roof, right? So last week, 5,200 cases, and it's truly remarkable and overwhelming already. This week, and this was this morning, we had 752 cases. We're up about around 1,700 now for the week. So testing, if you think about the what it takes to get a person tested, the staff and the facilities and the equipment, I can tell you Cherokee Nation is absolutely doing remarkable. The availability of testing to the Cherokee citizens and our other healthcare beneficiaries in the area is remarkable. And Monday on the holiday, our executive director made a call to set up testing at most of our clinics, and the staff answered that call, and we tested over 1,700 people on a holiday, right? And you see the number of tests we did last week, and we're going to be around that number again this week. So the number of people tested per week, again, this is just Cherokee Nation Health Services. You can see almost 14,000 people we tested last week. The staff, with the freezing cold weather and the snow, they're still out there taking care of the people and getting them tested. So Lisa, do you want to talk a little bit about our public health efforts and what we're actually doing within our public health department?
Sure. Thank you, Dr. Gann. We, as Dr. Gann said, we make about 800 to 900 calls a day. That includes, we try to do a case investigation on every case that comes in, but when you have over, 1,600 or 1,300 in a day, it gets really difficult. Our entire public health staff that usually works on other things is now working exclusively on COVID. Those calls are from people who have tested positive, people who are trying to find out what their test results are, people who are asking for guidance, they need notes for work. Some people call and they just want some reassurance that that things are going to be okay. So our staff field a whole lot of different calls. Our focus right now, because we can't get to every single case that comes in, it's just too many in one day, is to make sure that all the Cherokee Nation services are up and running. And so making sure that we can get our employees back to work as quick as possible. And making sure that they're okay. And then we're also working closely with leadership and communications to try to get out up-to-date information to the public. There is a lot of information coming out from CDC, and we're trying to stay up to date on that and sift out and put it in plain language and get that information out to our people in the communities and in our employee workforce. Thanks, Dave.
Thanks, Lisa. So the rules for the Omicron variant are the same as we've lived with for a while. The best way to prevent infection and severe illness and hospitalization and death is to be up to date on your vaccinations. It gets a little confusing when you go to the CDC website of what that means, but we'll go through that in a second. And then the number one rule of COVID is if you have symptoms, get tested, right? The sooner you know that you're contagious with COVID-19, then you can isolate yourself and stop the spread. Masking in public and avoiding large public gatherings are also key. CDC put out some new guidance on the different kinds of masks and which ones work better than others, and then distancing and hand washing. So, we hear the Omicron variant, it's milder and it doesn't really do much. And it's people, the definition of severe disease for medical professionals is different than what you might consider in the public. So if one of my patients has fever, body aches and pains, has pneumonia, but their oxygen levels are up and they're sick for 10 days or 2 weeks, that's moderate disease, right? Severe disease is in the hospital and very ill, and critical disease is when you end up in the intensive care unit. So don't be fooled. The people still get sick from the Omicron variant. It's not a pleasant thing to have. The getting tested, as I mentioned, is the #1 rule of COVID. The symptoms are pretty much the same as what we've experienced before. The main difference that I'm seeing locally is there's pretty rarely a loss of taste and smell, which was before kind of the hallmark of COVID. A little bit less coughing and more of just a sore throat and congestion. A little bit less pneumonia, but still plenty of people getting pneumonia and needing treatment for that. And of course, we have the monoclonal antibody treatments, and the drug companies are rolling out the oral antivirals, and we're getting those into our most vulnerable population and doing a good job of keeping people out of the hospital. So this is the vaccination recommendations. So if you received the Pfizer vaccine, that's for 5 years and older, 2 doses given 3 weeks apart, and 2 weeks after that, you're considered fully vaccinated. And then booster dose is for anyone ages 12 and older, at least 5 months after the last primary dose. And there's some other caveats there. And once you receive your booster dose, you're considered boosted and up to date. It's not 2 weeks later as with the original series. Moderna is not too much different. The primary series is given 4 weeks apart instead of 3. And then the booster doses are just for those 18 and older. And then the Johnson & Johnson vaccine, it's a single dose, and then you're eligible for the booster dose 2 months after receiving that. And when it gets this complicated in options, go see your primary care provider or a physician that you trust and discuss it with them about booster doses. There's no recommendation yet for a second booster dose. And the early data is showing an increase in antibodies with the second booster dose, but they're not really sure that it's adding additional protection against the Omicron variant. When we ran the numbers for that week where we had 1,900 cases, about 7% of those people were up to date on their vaccines. So they either had received the primary series and weren't eligible for the booster, or had received the booster. So the other 97% or 93% had not received the booster when they were eligible or had not been vaccinated. You can see in Oklahoma, our vaccination rate isn't close to high enough to prevent any surge or to consider herd immunity at 54.3%. And then of those who are fully vaccinated, only 33.7% have received the booster. So we have a huge vulnerable population in Oklahoma. And so I suspect the numbers are going to keep going up for a while. I think the rate of increase is going to slow down, but we're not going to peak for at least another week, more likely 2 weeks. The models just can't really fit well with the Omicron variant. There's too much we don't know about it, but we're learning quickly. So vaccination is important to take care of you and your family. You might still get the virus, but you're not going to end up in the hospital. It's very, very important. And that's the end. Before I wanted to share, be glad to answer questions. I know there's just a lot of concern and uncertainty in the news that's out there.
Okay, if anyone has questions, you can put them in the chat, please. We didn't receive any in advance this time, which is a little bit unusual. Let me ask a few that I jotted down while,
Sure.
As you were speaking. Is there any way to know, I think I read something today. Let me start it a little differently. I think I read something today that the experts in this only begin to believe that they're beginning to start seeing deaths from Omicron, that they've believed that many of the deaths up to, recent weeks or recently have still been from Delta, precisely because of this 3 to 4 week lag that you talk about, and being able to begin seeing deaths and counting deaths. Can you speak to that a little bit?
I haven't seen any data on that, Julia. And the problem is it takes a while to get a virus sequenced, and there's no clinical utility, meaning that if I'm taking care of someone with COVID, the variant that they have won't change the way I treat them. So it's more of an epidemiologic public health matter, and that the state is working very hard to get the viruses sequenced to see what's happening in our community. Their estimate is that right now 80% of our cases are Omicron variant. But I think they've only sampled, the report I got today, they've only sampled 22 cases for this month. And we've had about, I think 50,000 cases in January so far in the state. So it's just not useful information. We know that just watching what Omicron's doing, that it outcompetes Delta in the community. So yeah, there's probably still some more Delta variant out there, but it's hard to tell for sure.
I just wanted to kind of bring that up because anecdotally, it seems to me that this, the information that's kind of gone around is that, yes, it's very much more transmissible, but it's milder. And so there seems to be a sense on the part of some people that this one isn't going to kill you. And I don't think that's accurate, right? It can. And
yeah, so it's a percentage thing. So the risk of death with the Omicron variant is lower than with the Delta variant. We know that for sure. So when I'm talking to my patients about surgery, and I say, okay, you're going to have this surgery and these are the risks, but these risks are low. But it doesn't matter if the risks are low if you're the one that suffers that complication, right? So it's still a very dangerous virus, and it's hurting people and putting them in the hospital. And again, still in the US, 1,700 people a day are dying from COVID-19. So if lots of analogies and metaphors, right? When I have a Honda Civic and I have a Volvo station wagon, right? I know the data tells me the Volvo station wagon is safer, right? But I'm still going to wear my seatbelt, in the Civic and in the Volvo station wagon, because who cares if death is rare in a Volvo station wagon if I die, all right? So the COVID is nothing to mess around with. And I really enjoy the reports I'm seeing where officials are encouraging people not to get infected to become immune, right? Because our hospitals are overwhelmed. So if only 1% of the people who get COVID need hospitalization, we can't handle it. So the key is vaccination, getting your booster, and doing the best you can to avoid exposure.
Okay, we have some questions in the chat now. If we have to attend meetings masked and in person, how far apart should people be seated?
So first, with the amount of virus that's in our community, if you can get your hands on an N95 mask, that's number one. So it does a really good job of filtering. There's the KN95, which is a little less effective. And then the data still say 6 feet apart. There's most of the viral transmission is through droplets that generally don't travel very far. But there's still some aerosolization concerns. So the tiny drops that stay in the air for a long time. Some other keys to help prevent transmission: outside's better than inside, ventilation, windows open, the length of time you spend in the room. Singing creates a lot more droplets than talking. So, when the kids programs at school where they sing, which is a beautiful and important part of our culture and what we do, if they're not wearing masks, that's going out there. And so think about all those ways to minimize your risk. So 6 feet apart, N95 mask if you can, and ventilation. If you're setting up the meeting, have the fans going. If you can open the windows, it makes a huge difference.
This is a question I've asked in committee meetings, something along these lines, at least. Are there statistics regarding the percentage of children under 5 who require hospitalization?
Now, the risk is really low. So there's reports when Omicron started in the Northeast of the tremendous increase in hospitalizations of children. And the statistics were correct, like, 100% increase, 75% increase. The numbers are really low. So the last number I saw in the US, it was last week, there are 330 children in the United States admitted to the hospital. When you think about just in Oklahoma alone, we've got 1,300 people, including, I think there are only 28 children in the last report. In Oklahoma. So the risk is still low. It's not zero. And if you have children, do the best you can to keep them from getting infected. And when they do, the first rule of COVID, if you have symptoms, get tested. And if they test positive, check with your pediatrician on the best way to treat them and stay home.
Here's one I know that we like to hear about every time. How are the medical personnel holding up in the Cherokee Nation after 2 years of this?
Yeah, my impression is they're doing well. So I went to labor and delivery just about an hour ago to see a patient, and we had 5 women admitted, and every one of them had COVID. So it causes anxiety and it's more work. And they weren't hospitalized because they had COVID. They just were having a baby while having COVID. But even with that, it's a lot more work. And I heard today we're expanding our inpatient capacity. We have kind of an overflow section so we can admit more patients because we're running out of room. So the staff are doing okay. What we're struggling with now is staff who are getting COVID because this is so contagious. And the nurse managers and our hospital and clinic managers are all day long keeping services open, finding staff, taking care of the staff. And at public health, we spend a lot of time making sure that the staff have what they need at home and answer their questions and get them back to work as soon as is safe.
And the next question is about future variants. And I think this is also could lead us into understanding more about what does endemic mean? What are we beginning to hear about if and when that may be coming up in the not too distant future, that we are declared to have reached a place where this is just endemic? Can you just generally talk about variants?
Sure. So
what this can lead to?
Yeah, it's kind of more of an intellectual conversation, right? Because we don't know what the future holds. If you look at the influenza, every year we have different variants. It circles around the globe. And most likely that's going to happen with COVID, that we're going to have something new to deal with. Now, what we've seen in the past with other viruses, such as influenza, is that we end up with a virus that's highly contagious but causes very little severe disease, very few hospitalizations, and it still does. So the nightmare scenario would be to have a variant as contagious as Omicron, but as deadly as Delta or Alpha. And how the genes get recombined around the world and are able to take off is a matter of chance, right? And so when you get a variant that is highly contagious, it takes over. So it depends on what other genes it's carrying. And as far as the severity of disease, it's the ability its ability to evade our immune system. So with the influenza epidemic of 1918, 1919, all the people who got sick the first time didn't get sick the second time. But when the third wave came, the people who got sick the first and second time weren't immune, and they all got sick. And so, again, it's a matter of chance and what genes come about. So we don't know what's going to happen. The more people that get infected with COVID, that's another chance for the virus to recombine and come up with something super nasty. So what endemic means is that we have a constant level of disease in our community, but it's under control, right? So we don't have the big surges going up and down. I've heard some epidemiologists in the United States say when we get to 100 deaths per day, that's what endemic will look like. And hopefully, you know, our treatments will get better and our ability to diagnose will be better. And we can get people treated so those deaths will continue to go down, but people will still be getting coronavirus. There's debate about if it will become seasonal like influenza, and we don't know. It seems to me that it will, just like we've been dealing with 4 other coronaviruses that cause the common cold for years, and they're seasonal. So hopefully this will happen as the whole planet gets some kind of immunity. And I just don't know how long it's going to take, right? I think about how many more times can we do what we're doing today, you know, like we're doing with Omicron and we did with Delta. And, you know, no doubt in my mind that the Cherokee people, you know, can deal with this. And, you know, the leadership we've seen from the chief and his staff and health services, we can deal with it, but we don't want to, right? It's really detracting from all the other important work that we have to do: heart disease and obesity and cancer and nutrition and physical activity and historical trauma, right? All these things that we've got work, you know, a lot of work to do. We need to get this under control so we can get back to our real job.
And would it be correct to say that the higher the numbers of people who are vaccinated, the more it reduces the possibility for additional variants to emerge?
Yeah, for sure. So, you know, the data show that people who are vaccinated and do get COVID have less virus in their body, so they're not as contagious, and their body's able to get rid of it. So that, you know, the vaccine isn't a yes or no, it's a matter of degrees. So the vaccine's always going to help. And then the health of your immune system at that point is important. So one of our tribal counselors, Counselor No Fire, you know, talked about the importance of nutrition and physical activity and you know, vitamins to boost your immune system, in addition to all the other things you have to prevent COVID-19 and reduce the risk of burden. So all those are important. So yeah, we'll have to see.
The next couple of questions are about testing, and I've tried to stay pretty informed myself about this all the way through, but I'll tell you right now, I will frankly admit that when it comes to what's happening right now, the information about testing has got me more confused than I've ever felt, I think, throughout these last 2 years. And I don't know up from down on this one, I feel like. So can you help us out with this?
I'll try. So think about the easiest way to categorize is there's 3 different kinds of tests. There's the antigen tests, right? The ones you can do at home. It's a little card and nose or saliva and whatever. Those look for the protein code on the outside of the virus. Then we have this rapid PCR that we do here. We use the Abbott ID Now, and it's a PCR. It looks for the viral RNA. Then there's a little bit better test that takes longer to run. It's more expensive, and we can't do as many that alters the temperature. So it's a different kind of PCR. And so those we actually send out to get done, most of them. Our hospitalized patients, we have a machine that can do 8 tests in an hour, I think, maybe fewer. It's really expensive and it takes a long time. So for the antigen test, most widely available, there's 30 or 40 different companies that make them. And each test has their own characteristics about how good they are at detecting someone who has COVID, as well as detecting someone who doesn't have COVID. So if we call it sensitivity and specificity. What's the chance if you have COVID, what's the chance you're gonna have a positive test? So with the antigen test, the best approach to it is that if I have a high risk of having COVID, meaning I've had an exposure, there's a lot of virus in the community, and I'm having symptoms, and I have a positive antigen test, you've got COVID, right? So the test matches everything else, the symptoms, the exposure, you have someone in your household who's sick. The routine testing that we do, people who are not having symptoms, and we do an antigen test, if that's positive, then we do a confirmatory test with the PCR. I've seen several cases, but it's not a huge proportion of people who have no symptoms test positive and 2 days later start having symptoms, right? And so it gets a little tricky. So you put the whole picture together. The Abbott ID now that we do here is good. It's not the best, but we can do a whole bunch of them every day, and 12 to 1,300 of those a day. I forget how many machines we have, but when you've got an outbreak like we're having, getting rapid test results is important to help control the disease from a public health perspective. So again, I think the important thing is if you're having symptoms, get a test. Doesn't matter what kind. And if your test is negative and you get sicker, get tested again. And if you're not sure, go see a provider. They can test you for the flu, for strep throat, for RSV, for the other coronaviruses that are out there. There's a virus we've seen several cases of called human metapneumovirus, which is something we know about, but it gives people pneumonia. It makes them very sick. It's just not nearly as contagious as the coronavirus. So it doesn't have to be corona if you're sick. And if you're not sure, go see a provider, a physician, or a nurse practitioner that can take a look at you and listen to your lungs and talk to you and try to figure things out, because it gets complicated.
There are a couple of specific things related to testing that are in the chat here. Of what value is taking a test for measuring antibodies?
So we haven't figured out yet. You can do a test that's a yes or a no. It's like you have the antibodies, you don't, and it's got to be the antibodies that you would get when you get infected, as opposed to the antibodies you make when you're vaccinated. So you have to make sure of that. I think most of the blood donation people are testing for both the kind of antibodies you get when you get vaccinated and when you get infected, but that's something you want to check. So it's not of value today, like for me as a public health official, because we don't know if the presence of those antibodies protects you. And then even if you get a test where we measure the level of the antibodies that you have, so you get a quantitative value, we don't know at what value that you're protected. So we're seeing a lot of reinfections with the Omicron variant, but it seems that we haven't come up with the averages yet, but a lot of people who are getting reinfected, it's been a year or more since their last infection. Now, we've also seen people that had Delta like 3 months ago, and boom, they got Omicron and they're sick. And they're symptomatic. It's not a mild, sorry, the day started early this morning. So, so it's what I would call not mild, right? So they're fever and aches and pains, and they're out of work for a week, and they feel bad, and they can't take care of their kids, and et cetera. So it's not hospitalized disease, which is good, right? So I don't think, as a person, I haven't had an antibody test. I'm really curious if I had COVID sometime in the last 2 years, but it doesn't really help me make decisions about what I do when I leave my home.
So if I'm hearing you correctly, this notion of natural immunity is not a very reliable thing for us to bank on.
It's not something I'd use to make decisions about should I get vaccinated, should I wear a mask, should I go to my nephew's birthday party, should I go to church, and all of those. So it doesn't help you make those decisions. I think in the big picture, the more people who have antibodies on the planet, it'll help. But it doesn't help me make the decisions I need to make today.
And then another specific question here. Does the PCR test show positive results after the person is no longer infectious?
Yes. And so some really good data came out on that. And so if you look at the CDC guidelines, when someone becomes infected with coronavirus, they can get tested on day 5. And if that test is negative and they haven't had a fever in 24 hours and their other symptoms are improving, they're less likely to be contagious. They still think maybe a third or 25% of those people will still be contagious, but the risk is pretty low. They recommend you use an antigen test on that day 5 and not a PCR, because a PCR can stay positive. The viral RNA can be in your body, but you're not contagious for much longer, up to 90 days. But for the antigen test, it's less likely. Now, remember, all these tests were designed to diagnose someone with COVID. They weren't designed and tested to figure out if someone was still contagious after they've been diagnosed. So this is just data CDC is doing the best they can with to make these recommendations to both keep our society running and also keep our hospitals functioning and our communities safe. Really hard.
Lisa, can I ask you a little bit about the workforce? Can you talk a little bit about the employees and what's being done there?
I can speak generally to that. I wouldn't want to speak too much to the policy of it. I do have a general idea. We are, as a government, testing employees twice a week now, and with antigen tests. Mostly these are people coming to work that have no symptoms. If someone's symptomatic, we encourage them before they ever get to work to go get tested somewhere and make sure they have tests. And the workforce, we're catching cases. This is only the second week. Eventually, Chief of Staff would be able to explain to you the phasing in of the antigen test for the rest of the workforce. But and just on the second week, the day we're coming across 20, 25 people in one day, and that's helping to not create spread amongst our workforce. If we can get someone out who's contagious and maybe not having any symptoms yet, and we can keep that rest of the workforce safe, that is one of the most important things, and then get everyone back to work. I'm not sure how long that testing is going to last. I really am not that familiar with their policies. I know that Dr. Gann and our role as public health officials is that anyone that tests positive, any employee that tests positive, comes to us for guidance, isolation notes, and care throughout that time of that they're sent home for isolation, and helping them get back to work as soon as they can. But I do know that it is an initiative of the Chief's office and this administration to keep as many people safe and to ensure that we're there to take care of the citizens and other needs that they have. It's important that our WIC staff stays there. It's important that all of our staff that are providing other services and life-giving services in other areas are able to do their jobs. And so this helps if we can keep the spread down amongst our workforce and keep everyone healthy so that we can help you be healthy too.
Thank you.
I think I'm going to add to that quickly, Julie. I think it's really remarkable that the Cherokee people have a whole group that they can call when they test positive or they're exposed or someone in their family is sick. In the general public, that's really hard. But the way the chief and what Lisa has done with our public health workforce, it's designed to take care of the people that need help as quickly as we can. We have a hotline where people leave messages, and it might take us a few hours to get back to them when we're in the surge that we're in today. But it's people that they know and trust, before all of this started, that they can talk to. So I'm just so grateful that Cherokee Nation has been able to do this for the people. Really, really special and unique and not common at all.
No, I would reinforce that because I in various capacities have engagement with other tribes across the country, and they're absolutely astounded that we have something like this as a tribal entity, you know, because so many don't. And I will just jump on here as well and just say I have the utmost appreciation, respect, regard, love for our medical personnel and for our public health personnel, because this has really put everybody to the test. And you guys have just been phenomenal, just absolutely phenomenal in all that you've been doing. So I know there is gratitude across not only the workforce, but the whole nation, right, for all of your efforts throughout all of this, throughout all of the communities here. I want to ask about just what I had a thought earlier. Is this program that you're doing tonight and all of the others that you've done for us over these last couple of years for the at-large people in this remote virtual type of setting, are you doing this in other settings as well with other community groups, other organizations? Can you share with us a little bit about that type of effort?
Go ahead, Lisa.
I was just going to say, I was going to turn to Dr. Gann. He's been doing a tremendous brag on him a little bit. He makes himself available for lots of Zooms with school superintendents, getting a group in, or school officials or other people that want to have a town hall like this, ask questions, get guidelines, because as you know, CDC's guidelines for different settings are a little different in each place, and each school has their challenges. So Dr. Gann has been their own, so to speak, Dr. Fauci to help them through that time. I know that we're looking at doing some additional town halls coming up over the next couple of months, so that, or at least the next month, I think, to help out and get more information out to people and answer questions that we can answer. Because the more information we can get out, you know, and from people like Dr. Gann, who do this all day, every day, and can give you reliable information, trustworthy, unbiased information, it's really important to get that out. And so hopefully we'll be doing some more quickly. And Dave, go ahead.
No, that's what I was going to say. It's really the schools. The schools are, you know, our school superintendents and the staff and the teachers, their primary concern is the health and safety of their students. And it's confusing and it's hard. And there's so many situations that are different. All of our early head starts and child development centers we have around Cherokee Nation, every day, all day long, they're calling, asking for advice on how to help. And don't forget too, that with Lisa and me, we've got a whole team of Cherokees with advanced degrees in public health and in biomedical sciences and epidemiology, taking care of their people, and they're driven to work really hard to take care of them. So you see Lisa and me, but it's a huge team of Cherokees working hard. And Lisa's the one that put that team together before COVID hit, right? So again, we're really fortunate to have the resources that we have. And our communications department is working with us daily to get information out. And you know, we accept invitations whenever we can to speak in situations like this.
There's another question. Does the Cherokee Nation do sample testing each week for employees, or is everyone testing each week? And we were actually talking about this a little bit amongst the presenters tonight, just before we admitted everybody to the meeting. And our chief of staff was not able to be here tonight. I think he would probably be able to answer this. But we were kind of thinking, we're not really sure. Is that right, Lisa? Dr. Gann?
Yeah, I would apologize. It's just getting off the ground, and I would hate to speak and give you the wrong information. So Dr. Gann, probably, do you know anything different?
No, just in general, that routine testing of employees that are providing critical services like this, the science is really good that it helps prevent the spread of the disease. It's a burden on the Cherokee Nation government to conduct it, and of course on the employees that are getting tested once or twice a week. But it works, and it's temporary, and we have everything we need to take care of someone if they test positive. So I think it's a good temporary measure when we're in the middle of a big surge like this.
I heard you use a term in our last health committee meeting, Dr. Gann, something about COVID weariness. That wasn't the term you used, but that's what it meant. And I've forgotten exactly what you said, but
it's caution fatigue, right?
Okay.
I miss going to church, and being anxious at the grocery store wears on you after a while. Missing an important family event, funeral, a wedding, a birthday party, being stuck at home for 10 days because I've been exposed or I've tested positive, worrying that the person next to me has COVID, right? It's really, really hard on people, and it wears them down. So the caution fatigue is there, and it's real, and we help people through it. I still get phone calls about, this is happening and I want to do this. Is it safe? And it's never a yes or no question. Well, if you have to go, let's talk about how we can make it as safe as possible. If you remember one of the analogies, I love car analogies. Someone called me and said, hey, I'm going to go drinking and driving this weekend. What's the safest way to do that? If I don't wear a helmet, is that okay? Like, no, the best thing is to not go drinking and driving. So these cultural events that we have are hugely important. And so if you really need to do them as safely as possible. And there's a lot of peer pressure out there. There might be a family that's, no one's vaccinated except me. And how I'm going to wear a mask when I go. What kind of pressure am I going to get from the rest of my family if I wear a mask, right? And those are hard on people, really, really hard.
Speaking of masks, I don't know if either one of you can address this, but there are, as I understand it, we're all being urged to, upgrade to at least a KN95, right? And yet it's my understanding that there are a lot of fakes out there. Do you have any advice on that point at all? You may or may not. But
I don't know. I know the N95s will have a stamp on them from the National Institute of Occupational Safety and Health. And there's still some different types within an N95. There's the medical grade and there's industrial grade. The KN95s, I'm not sure, Lisa, if they have some kind of certification on them or not. I don't know. I've got a bag over here. I don't think so.
Not the ones that I have are not. And I have some at the house too. And they actually, I would encourage anyone that can get their hands on an N95 or a KN95. Those are probably easier to access, but I've moved to wearing those, and my child wearing those to school, my husband, family, because they just provide better protection than even the surgical loop mask, and then even better protection, obviously, than the cloth masks. And honestly, no mask is better than, any mask is better than no mask, but the most protection is going to come out of the N95. Dave, do you want to show the KN95?
Yeah. So the real difference, KN95 has ear loops here, and then an N95 has two straps that go top and bottom. And it just gives you a tighter seal and different filtering capacity. The KN95 still is a 3-layer absorbent type thing. And what I like about them is that they wrap around the sides, where the regular blue masks, often they bulge out on the edges, so the KN95 and the N95s do a lot better job of filtering air that's coming in, but also absorbing the droplets if you do have COVID from leaving your body. So getting away from the mask. I think the days of the high fashion single layer cloth masks are done. They just, with the Omicron variant, it doesn't provide much protection at all. It's negligible. So.
We've got one last question in the chat, which is asking about telehealth counseling available. Is it available now through Hastings or other IHS services? I know we've done a lot of telehealth, regular medical, but this is specifically a question about the counseling services. And again, I don't know if either of you are able to respond to that.
I know that it occurs, but I don't know the standards that apply, if it's for every visit or first visit needs to be in person, or I don't really know. Lisa,
I do know that they are doing behavioral health counseling through our behavioral health services, telehealth. I don't know how much of it is telehealth, like Dave spoke, but I do know they are providing services in that way when it's possible.
Counselor Kidwell, do you have any questions or that have come up for you?
No, I don't really have any questions. I would add on the mental health counseling. We do it. My brother goes once a month to Hastings there and does his mental health visit with a doctor in Tennessee. So we are doing that. There's a lot of legal issues in expanding that out to the greater Cherokee Nation, but it is happening, and I do know that this administration, as well as the council and many of those, Dr. Jones and others at the health services, there are proactively looking at ways to expand that and make it more accessible to other people in the Cherokee Nation. I don't have a timeline for you. I don't know what that would be, but I know that we're doing it. We're actively doing it, and we're also actively looking at trying to offer it to other citizens out, even off the reservation, citizens at large, even.
Okay. Well, I don't see any more questions in the chat this evening, and we are a little bit over time, not as bad as we've been on some of them, but I do want to thank all of you. Lisa, Dr. Gann, Counselor Kidwell, we'll see you again on these town halls, I have a feeling, and we'll probably see the public health officials again on these town meetings, not because we don't love you and don't want to see you every time, but we do hope that this, gets down to a manageable level at some point. But until it does, we really appreciate the continuing updates and the great information and the very accurate information and expertise that you bring to us every time. So once again, thank you so much. We know it has been a very long day already for both of you, and we appreciate you being with us tonight.
You're welcome, and it's our pleasure.
And thank you to all who have attended this evening, and we'll see you next time on our town halls. Thank you.